Morning, everyone. Thank you for joining this Saturday for a very important topic about South Asians and the heart disease. My name is Dr. Srini Gangasani. I'm a cardiologist in Atlanta and current chair of the CME. I'm on call today, so I had to be doing this. I'm doing this from the hospital in between my rounds. Actually, I saw so far in my CVICU 6 patients this morning. 3 of them out of the 6 are South Asians. Wow. Had bypass surgery or a high-risk PCI. So I think that I was talking to them this morning. I said, okay, this is so much a more prevalent disease. And I think Brahma, our world famous cardiologist from Pittsburgh, when he brought it up, I think this is a World Heart Day being September 29th. I think this is a great topic for this week to kick off the World Heart Day. How heart disease is so much more in Indians and Indian subcontinent and South Asians. If you look at it, about South Asians comprise about 23 to 25% of world population. But we have about 55 to 60% of the heart disease patients in the world are from these South Asian countries. So I think it's a very important topic. I think we need to learn, and we know each day, each week, we see so many patients, our families, friends having the heart disease in their 40s and 30s and 50s. So I think it's a very important topic for us as physicians, as well as to educate other people. I really appreciate Brahma to take this into, and then getting 2 world-class eminent speakers, Dr. Jaideep and Dr. Shekhar, to give us insight into the South Asians and the heart disease. And I would like to introduce our president, Dr. Ravi Kohli from Pittsburgh for AAPI. So he's doing a wonderful job so far, and we've done wonderful CMEs. And I think a few weeks ago, he has done a wonderful job about CME, about physician burnout and suicide prevention. Without further ado, I think Ravi, take over. Thank you.
Good morning, everyone. Good morning, esteemed panel, for joining on a Sunday morning from taking time from your precious family time and other times that you probably cherish. And I want to thank all our members. Already 100 people are here, and I expect more people to join. I want to especially thank Dr. Jaideep Patel and Shekhar Kathrison, Dr. Kathrison. I think you're also originally from Pittsburgh, I believe, Dr. Kathrison. And we have an event tomorrow, and I think your dad is coming there. I'm looking forward to meet him there. And without further ado, I'll introduce my good friend, my colleague, Dr. Brahma Sharma, to start the proceedings. And we're looking forward to some great information being shared by the esteemed panel, and our moderator, Dr. Sharma, and Anita will also join soon. Thank you, and I want to thank AAPI office also for helping to facilitate this in a smooth way. Thank you, welcome and join.
Thank you, Ravi. Thank you for the AAPI leadership for taking this lead on making it annual sort of ritual on the World Heart Day to talk about something that is so close to our heart, literally speaking. And some housekeeping rules. We have 2 distinguished cardiologists, 2 co-panelists. Anita, Dr. Sharaf is going to join us soon. What we'll do that we'll start with Dr. Shekhar first, and then not take the questions and have Dr. Patel also talk about it. And then we will have a panel discussion for about 30 minutes. You can put your question and answer. Srini and Dr. Sharaf, and we will try to answer your questions as much as we can. So without wasting too much time, Saturday morning, let's start with Dr. Shekharan. So Dr. Shekharan is a Pittsburgher, as you heard. He went to North Allegheny School, right, in my neighborhood. But he went to UPenn for his graduation, went to Harvard Medical School, and he did unusual, phenomenal work. He's a leading scientist, physician. I can go on his publications. But his main focus has been discovering genes, some undefined, undiscovered links to the biology of the heart disease and South Asians as well. He's a geneticist, physician, and he's smarter than all of us. He left Harvard and MIT, has a position as a faculty, but opened a editing company, startup, Verve Therapeutics, which is a next generation base sequencing, but that is something we'll talk more. But basically his passion, his dedication, his intelligence in discovering these genes and connecting the dots together is known worldwide. He has too many titles, too many publications. I don't have time. He's got so many distinguished awards. So I'll just stop there, Shekhar. Thank you.
Dr. Sharma, Dr. Gangasani, Dr. Kohli, thank you so much for the opportunity to speak with you all today. It's really a pleasure and a privilege to share some of the research and work we've done over the years. I'll go for about 30 minutes, and then I think Dr. Patel will go after me, and then leave plenty of time for questions. So what I want to share with you is the work that we've done over the last 25 years or so, reading the genome for risk to now rewriting it for cardiovascular health. My disclosures. So let me start with the case. So this was these are the actual ambulance sheets of a 42-year-old South Asian male who presented with dizziness and profuse sweating. And what you can see here is highlighted. The stretcher was brought into the residence and the patient was getting ready for transfer from the chair to the stretcher when he started posturing and having a seizure. Ultimately, the patient was taken into the ambulance unit from the home. Once inside the ambulance unit, this was the first rhythm, the third row, clearly VFib, was shocked out of that. And you see at the bottom is the first rhythm strip. This is a acute IPMI. The patient was taken to the cath lab, had the right coronary artery opened, but unfortunately suffered a fair amount of anoxic brain injury during the resuscitation and expired 10 days into the hospital course. So unfortunate, 42, premature MI, complicated by death. Now, 6 months earlier, these were the risk factors in the patient. You can see that on the left there, the lipid risk factors, the LDL was a bit high, the HDL was a bit low, the triglycerides above normal. The non-lipid risk factors are okay, but you can see on the right there a very strong family history. So in red are each of the family members who've suffered coronary disease. At the bottom left here with a little triangle in black is the patient who deceased. But you can see the patient's father had an MI, it was actually at 54 years old. The patient's uncle died in MI, also 42, and the patient's paternal grandmother also had premature coronary disease. So a strong familial clustering of premature coronary disease. So when we see this, we immediately think the genome, right? Genetic factors. And so this is the problem that I've worked on most of my career. So really trying to understand what's going on here. So if you take the population at large and you think about the DNA and you think about the average individual has average MI risk, okay? But some individuals might carry a genetic factor, like maybe this patient, and as a result of that genetic factor, they have higher risk. So that's one of the questions we've worked on. The second question is, some people are actually protected based on that genetic factor. So they might be resistant to heart disease. So what's the genetic basis for resistance? So that's the second question that I'll go over. And then lastly, this is the latest chapter in our work, is can we actually rewrite the genome in an individual to reduce risk? So these are the three questions I want to go over with you, the answers we've gotten to each of these questions. So let's start, just a little bit of background, of course. So myocardial infarction, leading cause of death in the world. There's a chronic phase to the disease, several decades of plaque buildup in the wall of the artery. Then there's an acute phase, right? Plaque rupture, in situ thrombosis, cessation of blood flow for more than about 20 minutes leads to death of heart tissue, myocardial infarction. So detected by symptoms, EKG changes, elevation in cardiac biomarkers. This disease, like many diseases that we see in everyday practice, is what's called a complex trait. So it's a combination of heritable factors and lifestyle components. And for about half of all MIs, as you know, the first presentation involves sudden death. Okay, now what are the, one of the interesting factors that we're all focused on is the specific risk in South Asians. So this has been nicely quantified by a trainee from my lab, two trainees actually, Anirudh Patel and Amit Kara at the bottom. They published a paper last year looking at the risk in South Asians compared to those of European ancestry in a very large cohort study called UK Biobank. So this had about 8,000 people of South Asian ancestry, about 450,000 people of European ancestry. They were all without heart disease at baseline, followed for an average of 11 years. And you're simply tracking how many people, what fraction of South Asians versus European ancestry individuals got heart disease, atherosclerotic cardiovascular disease over the 12-year follow-up period on the bottom, on the x-axis. On the y-axis is a cumulative incidence rate, and it's very striking. So what you're seeing here is a twofold increased rate of events in the South Asian group compared to everybody, compared to the European ancestry group. So I think, you know, we all wonder why. And they did some work in this paper to look at some of the traditional risk factors. And they do explain a bit of this risk, maybe about half of it, but still another half is unexplained. And this is, I think, a work in progress, really, as to why South Asians are so much higher risk. Now, in terms of thinking about other risk factors for coronary disease, established risk factors besides ancestry, the best understood, of course, are lipoproteins. So they're schematized here. Lipoproteins are our body's way to transport triglycerides and cholesterol in the blood. And what you can see is that these lipoproteins are little spherical balls. They have a phospholipid monolayer and a protein embedded on the coat. And then inside the little ball is lipid, is either triglycerides in blue or cholesterol in orange. These lipoproteins are named based on the density, so high density lipoprotein for HDL all the way on the left, or based on, or low density lipoprotein, LDL, or based on the lipid they carry. So triglyceride-rich lipoproteins collectively carry triglycerides mostly in the center. Now, you can also differentiate them based on the protein that's on the coat, on the phospholipid monolayer. All the ones on the right, you can see have ApoB on the surface. And that ApoB, so collectively, these lipoproteins are called ApoB containing lipoproteins. So that's LDL, lipoprotein little a, and triglyceride-rich lipoproteins. In contrast to that, HDL has ApoA1 on the surface. Okay, so these are the best understood risk factors. If you come back to the key question I started with, the first of the three questions, what's the inherited basis for risk? So to understand the inherited basis for risk, we started in 1997 when I was an intern at Mass General Hospital, enrolling patients who suffered MI at a young age, men less than 50, women less than 60, and over several years, we recruited several hundred patients, and then combined with a lot of other studies around the country and around the world who had similar collections of patients, and systematically analyzed the genomes of patients with disease and without disease to see where in the genome does risk come from. That work, spanning roughly 10 plus years, led to two answers. There are basically two major inherited paths to heart attack risk. One is the monogenic model. So that means a single gene mutation is sufficient to lead to early disease. Then the second model is called the polygenic model. That means the additive effect of many mutations, many DNA variants in aggregate lead to disease. So let me walk you through these two models. For the first model, the monogenic model, there are at least 5 genes where mutations in those genes have large effects on myocardial infarction risk. The 5 genes are shown here. Each row is a gene. In the columns, you can see the gene name, the carrier frequency. So that means what fraction of the population carries the mutation. And then the blood lipid that's elevated as a result of carrying the mutation. And then lastly, how many fold increased risk the patient is at based on carrying that mutation. The most common of these conditions, the monogenic mutations, is LDL receptor. That's about 1 in 250 is the carrier frequency. LDL is elevated, and their individuals are about 4-fold increased risk. And this is, of course, the disease called familial hypercholesterolemia. That's the disease caused by LDLR mutations. Now, what all of this data really shows is that it's all about the cumulative exposure to LDL. This is really the root cause of myocardial infarction. On the x-axis is age, on the y-axis is cumulative exposure. The average individual, shown in the light blue line, crosses a threshold for clinical events, that's the gray bar at the top, at about age 65. So the cumulative exposure threshold for coronary disease events, clinical events, is crossed by the average person by about age 65. But individuals with familial hypercholesterolemia have very high LDL starting at birth, and that's the purple line, and they cross this threshold much earlier, like this patient that we just saw might have an MI here at age 42. So, so these are some of the learnings from the genetics research. Now, if you take sorry, one second. If you take the 100 patients with early myocardial infarction and ask what fraction of them actually can you find a DNA mutation that in one of those 5 genes, it's actually a relatively small fraction, about 2%. So about 2 of every 100 patients with early myocardial infarction, you can find a mutation in one of those 5 genes. And as I said earlier, the mutation increases risk by about 4-fold. So what's going on with everybody else, the other 98 patients who might have had a heart attack in their 30s, 40s, or 50s? And there we evaluated a different model, something called the polygenic model, and are now looking at individuals with disease, without disease, and scanning the genome not for rare mutations in individual genes, but rather common DNA polymorphisms that are scattered across the genome. And we're systematically searching for differences in cases and controls in terms of the frequency of any given letter at a site in the genome across millions of sites. So this kind of comparison across millions of sites has been done here in this analysis of about 60,000 cases with premature coronary disease and about 120,000 controls. And what we found is that there are hundreds and hundreds of sites across the genome that confer risk. Each site actually confers a small amount of risk, maybe 20, 30% at the maximum. And then you can sum them all up across all these sites to get a score for each individual. So you can literally take all of the letters, here in this case, about 6.6 million common variants across the genome, and add up the letters to get to a score, what's called a polygenic score. And if you calculate that score in each person, and this has been done now each of several 100,000 people from that UK Biobank study that I mentioned earlier, and then you plot that, you get this beautiful bell curve distribution. Okay, so this bell curve is really a quantitative risk factor now. It's a new quantitative risk factor, a single number which captures your genetic liability to heart attack. Now, this kind of distribution looks very much like the cholesterol distribution in the population. If you plotted everybody's cholesterol in 300,000 people, this is what you get. You get a bell curve. Some people are high, some low, most in the middle. Here, this is not cholesterol, but rather this polygenic score being plotted. So the question then becomes, if you're high on this score, how much higher risk are you for heart attack? And could this score explain some of those patients who have early onset heart attack? And it turns out it does. This high polygenic score is actually seen in about 20% of patients with premature coronary disease. And having this high polygenic score, having a high polygenic score increases risk about 4-fold as well, to a similar degree as having an FH mutation, having an LDLR mutation. And what's important here is that this is not being tested for regularly in clinical practice right now. These patients are flying under the radar, right? You're not going to capture these patients by looking at their cholesterol, looking at their blood pressure, because this score doesn't actually track with any of those risk factors per se. So this is an opportunity for prevention. We're identifying these high-risk patients based on this polygenic model. may allow you to if you appropriately treat them, avert the disease. So that's okay. So that's risk, monogenic model, polygenic model. What about resistance? Because you often hear about people who may have had high cholesterol or risk factors for a lot of years, but never develop a heart attack, for example, or people that have smoked for a while but don't develop it. So the concept is mutations may reduce risk rather than increase risk. So this is something we've worked on. And why might you want to know about these resistance mutations? Well, the best reason is that they can guide the development of new medicines. So the example here is an LDL. Okay, so we all know that higher level of LDL cholesterol is correlated with increased risk. That's what's shown on the left in the epidemiology. But then there were some interesting genetic findings, one highlighted here, where there's a gene that I think almost all of you know, which is PCSK9. People that were identified that completely lacked this gene, they had lifelong low levels of LDL cholesterol, were healthy and resistant to coronary disease. And the LDL levels were really low, like 14 milligram deciliter in this one patient who completely lacked the gene. And about 1 in 50 African Americans in the United States actually lacked the gene in terms of one copy, heterozygous deficiency. They also had low LDL, low risk for heart attack. So this suggested that this gene was dispensable, that if you could develop a medicine that mimicked these natural mutations, that would lower LDL and reduce risk of coronary disease. And that's what people did. So several pharmaceutical companies developed monoclonal antibodies that basically mimicked the natural resistance mutations, basically neutralized the circulating blood protein. And as you know, those medicines were tested to lower LDL, to lower risk of coronary events in outcomes trials, and now are available on the market. So low LDL is really the best validated causal pathway for resistance to myocardial infarction. Now, beyond low LDL, by PCSK9, lacking PCSK9, there were 7 other genes that we and others identified where these resistance mutations resided. All of the 8 genes are shown here. You can see in each column is a gene. The fraction of the population that carries a mutation that protects them is in the 2nd row. The 3rd row is the blood lipid that's lower as a result of the mutation. The next row is the degree of protection conferred, how much lower risk is each person based on carrying that mutation. And then lastly, the medicines that have been developed or are in development that mimic those resistance mutations. So this is a really nice concept, I think, for you to take away, which is resistance mutations do occur in the human population, really for every disease. And those resistance mutations are being routinely identified now, and they are inspiring the development of new medicines that mimic those mutations. Okay, let's close by the latest chapter, which is, can we actually leverage all this information and use it to literally rewrite the genome in an individual person to reduce risk for disease? So this is really about the Verve Therapeutics story, and that story is built off of 2 key insights from human genetics. One I mentioned is that once LDL is low, lifelong, it's really hard to develop an MI. Second is there are a series of disease-causing genes like PCSK9 that are naturally turned off in humans and lead to resistance. Okay. These insights were nicely summarized by Dr. Eugene Braunwald in a recent thought piece. And the title of it is How to Live to 100 Before Developing Clinical Coronary Disease, a suggestion. And his suggestion was really to get the LDL as low as possible for as long as possible. So how can we do that? Well, imagine if there was a single treatment that would durably, maybe even lifelong, and safely lower LDL cholesterol. such a medicine really has the potential to treat, ultimately prevent this disease altogether. So this is the mission of Verve Therapeutics. Can we transform the care of myocardial infarction from daily pills, intermittent injections, to a one and done? So we turned to a couple of different technologies that had the ability to rewrite the genome to turn off genes, disease-causing genes. And so we were looking to turn off PCSK9 or another gene called ANGPTL3, which is very similar to PCSK9 in terms of being disease-causing or cholesterol-raising and needs to be turned off in the liver. Two technologies that emerged in the last 10 years to be able to do this are one on the left called CRISPR-Cas9, so-called molecular scissors. So it cuts DNA at a very specific spot that you tell it to go to, and then can turn off a gene that way. There's another technology on the right called base editing, which is kind of like a cousin of CRISPR or CRISPR 2.0 approach, that instead of cutting DNA, it's more like a pencil and eraser. You can guide this system to a very specific spot in the genome and then have it change one letter, an A, let's say at that spot, to a G. So it's literally like rewriting the genome at one spot at a time. So this technology called base editing emerged just a few years ago. So we got access to both of these technologies and have now evaluated the ability of these technologies to turn off the PCSK9 gene initially in liver cells, and then in mice, and then ultimately now in monkeys as well. So the drug that we've developed is shown here. This is a drug product that has in the center of it an mRNA for the base editor. That's the protein that will make that spelling change, DNA spelling change. Then there's a guide RNA that tells the editor where to go to make that change. Both of those nucleic acids, these little squiggles in the center, are packaged in a lipid nanoparticle. And so the drug product is shown on the right here, electron micrograph. The drug product is infused into the bloodstream. It's an intravenous one-time treatment over 60 minutes. The drug goes to the liver. This is how it all works. So the 1X is a one-time treatment. Here's the drug on the left. The middle panel shows that the drug, once in the bloodstream, goes to the liver, is taken up by liver cells. Once inside liver cells, ultimately makes its way to the nucleus and makes that A to G spelling change in one spot out of the 3.2 billion letters in the genome. What we've done is with our first medicine, we're making that change in the PCSK9 gene at the end of exon 1. The consequence of that A to G spelling change is to turn off the gene. Turning off the gene in the liver brings down the blood PCSK9 level, and the consequence of that is the LDL cholesterol level should come down. So this was the concept we started with in 2018. Over the last 4 years, we've been able to develop this medicine and test it in non-human primates, in monkeys, testing this adenine base editing. That's the name of the editor, ABE. So the paper that showed this whole thing working in monkeys was published last year in the journal Nature. And the data from that paper I'm going to share with you in the next couple of slides. So again, the drug is given by intravenous infusion to the monkeys. There's one group that got the drug on the top. The bottom group got a control, just saline. And the monkeys had measurements made before treatment and then serially after treatment. And the monkeys have been followed now almost 2 years after treatment. The measurements are, we measure directly the amount of DNA that's been edited in the liver by taking a liver biopsy of the monkeys. We also measure the blood PCSK9 level. Now that should go down if we've done the edit appropriately and turned off the gene. We've also measured the blood LDL level in these monkeys. Okay, so here's the data. Initially, here is the editing level in the liver by DNA sequencing. And what you can see in blue are the control animals and purple are the treated animals. So there's 4 monkeys, each bar is a treated monkey. and 3 control. And what you can see is that the average amount of editing was about 67% in the liver sample, DNA from the liver. That consequence of that was about a 90% reduction in protein, PCSK9 protein, that's in the middle, and about a 60% LDL cholesterol reduction at 2 weeks. Okay, so we've turned off the gene, cholesterol comes down. That's at 2 weeks. So what about over time? This is now the PCSK9 blood level a year and a half later, 15 months later. You can see here, it's rock solid, stays stable. So the blood PCSK9 level remains 90% lower 15 months after treatment. This data has been extended out now to 2 years, and you see the same pattern. LDL cholesterol is similar. There's 60% reduction at 2 weeks, 60% reduction at now, here shown 15 months, also at 2 years. So this looks like we're going to have a one and done treatment for LDL cholesterol lowering. What we have here is, I like to provide an analogy. It's like molecular surgery. It's like surgery without a scalpel. We're able to make a single spelling change in the DNA of liver cells, nearly every liver cell, really, in a living animal. And the consequence is lower LDL, reduced risk, hopefully, of myocardial infarction. Now, that's the so-called on-target editing. That's where we want to make the spelling change. I'm sure all of you are thinking, well, are you making any spelling changes anywhere else in the genome? So-called off-target editing. We're looking at that here. On the x-axis is all the different chromosomal places that we've looked, broken up by different chromosomes. On the y-axis is the level of editing we're getting. The purple dot is the intended on-target site in the PCSK9 gene. That's the place where we want to make the edit, to turn off the gene. The black dots are all the potential off-target sites that we looked at, potential off-target sites, about 3,000 of them. And what you can see is all the black dots are all centered around 0, whereas the purple dot, the on-target site, is very high-level editing. So this suggests that the drug product that we have is very specific. We're making the edit where we want to make it. We're not making it anywhere else. Okay. So where are we with this medicine? So we started the company in 2018 with this concept. Over the last couple of years, we've done the animal testing. And just in July of this year, we started the human testing. So we're in a phase 1 study right now with the VERVE-101 product targeting PCSK9 in patients with familial hypercholesterolemia. We also have a second product that we're developing that edits a different gene called ANGPTL3. This gene raises both triglycerides as well as LDL. And turning off this gene lowers both triglycerides and LDL. And this has been tested in monkeys, and we're getting ready over the next year or so to bring this to patients as well. This is just some of the milestones for the first product, VERVE-101. The first human, as I said, was dosed with this medicine over the summer as a potential treatment for heterozygous FH. This is the Heart-1 trial of heterozygous FH patients. About 40 patients all have the LDLR mutation. They all have established atherosclerotic cardiovascular disease, and their LDL is unacceptably high on oral standard of care. We have 4 doses that the patients will be getting. Each dose group has about 3 patients. And then there's an expansion into a Part B, larger number of patients. So this study, we will have clinical data in the first 12 patients next year in 2023. So we will understand the safety and hopefully the efficacy as well in terms of PCSK9 blood reduction and the blood LDL reduction in the first 12 patients. We'll have the data next year. Ultimately, this is how we see this medicine being developed. First, for HeFH, the heterozygous FH patient population, which is about 1 million people in the US, 2 million in EU and UK, and 31 million globally. So it's a very common genetic disease. Ultimately, we can see this medicine also being developed in patients with garden variety atherosclerotic cardiovascular disease as well. And eventually, of course, this could be a preventive therapy before somebody has an event. So just let me close with these last 2 slides. This is the current model of care, right, for coronary disease. It's chronic care, daily pills, intermittent injections. So think about a hypothetical patient with heterozygous FH. That's what's described here. On the x-axis is age, on the y-axis is LDL cholesterol. The patient has very high LDL, let's say here 200 from birth. As you know, it's often unrecognized in these patients until they have their first event. Here shown at age 44. The patient gets treated, gets put on standard of care, typically lifestyle and statin. The LDL comes down, but it may be still unacceptably high. They may get added a PCSK9 therapy. LDL comes down further. And over time, what happens though is the LDL typically doesn't stay down. There's oscillation in the life course because of access issues, adherence issues, healthcare infrastructure needs. Some of those items are described at the bottom. Because of these challenges with the chronic care model, there's oscillation in the LDL over the life course, and the patient may have recurrent events like a stent or bypass or even a fatal event. What we want to do is ultimately replace this picture, the chronic care model, with this picture. A one-time therapy that is durable, leads to dramatic lowering of LDL, and with a good safety profile. We think that this kind of medicine, a single course gene editing treatment, may really solve many of the challenges associated with the chronic care model for treating patients with ASCVD. Thank you.
Wow, that's amazing.
That's a mind-boggling concept that you have been working on, Shekhar. That's really amazing work. And
Right. Literally and figuratively, the cutting edge technology, right? Shekhar, that was kind of mind-boggling, like Brahma said. Yeah.
So
can you guys hear me?
If you can hang around, Shekhar, we have a couple of questions we'll take in the end, and we really appreciate your time. So next speaker, I don't know, Dr. Sharaf is on the screen. Hi.
Yeah, she's here. Yeah.
Hi. Dr. Sharaf is again from Pittsburgh. She's assistant professor at University of Pittsburgh, UPMC, trained at Emory, and also a preventive cardiologist, expert into women's heart disease, and congenital pediatric cardiologist also. Anita, go ahead and introduce Dr. Patel.
Yes, thank you. Hello, everyone. I have the pleasure of introducing Dr. Jaideep Patel. He graduated from University of Antigua. He did his internal medicine residency at MedStar and VCU, and is now the director of preventative cardiology at the Greater Baltimore Medical Center in Johns Hopkins. And today we have the pleasure of having him here to talk about ASCVD risk identification and use of coronary calcium amongst people from the Southeast Asian ancestry. Please welcome Dr. Patel.
Great. Thank you all for the invitation to come speak today, Dr. Kohli, Dr. Sharma, Dr. Gangasani, and Dr. Saraf. Thank you for that kind introduction. It's actually really quite an honor to be sitting here on the panel and discussing this all with you today. I wanted to take some time to talk about South Asian risk and how we refine that risk. And I certainly don't have to remind anyone of this, but it's important for us by stating that South Asians are those who trace their ancestry from places such as Bangladesh, Bhutan, India, the Maldives, Nepal, or Pakistan. And this is certainly different from those from Southeast Asia, for example, which is a common source of confusion. In light of today's discussion, it's also important to note that South Asians living in any of these countries or in the diaspora suffer from cardiovascular disease at a rate double that compared to those of European ancestry. As we all know, cardiovascular disease remains the leading cause of global mortality and is a major contributor to disability worldwide. And notably, while the global prevalence of CVD has continued to increase over time, some of the highest changes related to poor cardiovascular health are found in South Asian countries. Closer to home, this is a nice paper written by a close friend and collaborator, Dr. Nilay Shah at Northwestern, showing that compared to other Asian groups living in America, Asian Indian men and women have the highest ischemic heart disease mortality rates seen here in the green lines. And this builds on some older data from the early 90s from Dr. Jose Powell, who's out in San Jose now. And notably, while rates were actually downtrending, as you can see, for all Asian groups, we started seeing an upswing in mortality as of 2011, particularly in Asian Indian men and women. And so the question is why? Why is this risk higher? Certainly all of the panel members here today have been working hard to try to answer that question. But I think to understand the why and the challenge of managing cardiovascular risk in this group, we have to understand its origins. Over the course of time, this continent has been under the rule of various empires that have influenced the region by bringing with them their own culture, language, identity, cuisine, and religion, for example, certainly enriching the fabric of the area. But this has also likely driven political and geopolitical differences amongst ruling groups. And so the South Asia that we know today is the result of imperialism and rule under the British. Around 1600, a British trade company called the East India Company was established to facilitate trade with the East. And it wasn't until rebellions against the same East India Company by native South Asians that forced the British to kind of reorganize its army, its financial system, and the administration in India, ultimately putting India under the direct rule of the British government in what was then called the British Raj. Fast forward to 1947, where we saw the British abruptly leave the subcontinent, partitioning into two independent self-governing nations, a Hindu majority India and a Muslim majority Pakistan. And immediately there began one of the largest forced migrations in human history, as millions of Muslims trekked to West and East Pakistan, while millions of Hindus and Sikhs headed in the opposite direction. And across the subcontinent, communities that had coexisted for almost a millennium attacked each other in a terrifying outbreak of sectarian violence. The formation of Sri Lanka came about politically in 1972. And ultimately, a war between East and West Pakistan resulted in the formation of modern-day Pakistan and Bangladesh. And so what we're left with is what looks like modern-day South Asia, all of which ultimately influence their personal view of healthcare. So what about immigration to America? Well, after initial documentation of Punjab farmers, there was little immigration in light of discriminatory regulations. Naturalization rights and extended immigration quotas allowed 100 Indians and 100 Pakistani adults per year to come to the United States, thanks to laws that were passed in 1946. And then these quotas were lifted in 1965 and encouraged skilled professionals from South Asian countries to immigrate to the United States. Finally, a third wave occurred in the mid-1980s, which allowed parents and extended families of those same set of professionals to come to America. And this is reflected nicely in South Asian immigration trends from the 1960s, where many immigrants from India and Pakistan arrived, as you can see. And it wasn't until the 1980s when we started seeing trends in immigration from other South Asian countries. To date, Indian Americans dominate the South Asian immigrant population in the United States, as shown here in the green line. From a population perspective, South Asians are one of the fastest growing minority groups in the United States. And so it's imperative that the health needs of this minority group are critically examined for a variety of reasons. The first is to ensure culturally appropriate medical and health services. The second is to address a variety of serious health conditions that they face. The third is to create informed policy decisions. And lastly, it's to improve current and future clinical research in this group. We among the healthcare workforce certainly have an opportunity to be more influential. This is data showing that Asians are the majority of the minority workforce across all domains. So we as a community know these people, these are our colleagues, and supporting them and their communities may in fact help reduce healthcare disparities in this arena. Fortunately, there was a rise in awareness towards the end of the last decade, mainly starting with an American Heart Association scientific statement in 2018, followed by efforts by the American College of Cardiology and the National Lipid Association. Our team was certainly fortunate to have some of our work featured in this conversation as well with the American College of Cardiology. It's difficult to speak about South Asian cardiovascular health without talking about risk factors that may or not be necessarily unique to this group. I certainly don't want to be redundant about lipids, as we just heard an exceptional talk from Dr. Kathirasan. But I do think it's worth reiterating that there are common lipid abnormalities that we see. One is of atherogenic dyslipidemia, characterized by elevated triglycerides and LDL, but low HDL. In addition, the prevalence of a lower HDL has been shown as high as 50% in South Asians. Additionally, even at higher values, the protective effect of HDL levels seems to be weaker for South Asians presenting for first-time heart attack. Lipoprotein A is highly atherogenic and has been associated with premature atherosclerosis. Important to South Asians, LPL levels of more than 50 are found in about a quarter of the population. And this may be clinically significant considering that the population attributable risk for a myocardial infarction is highest in South Asians when the LPA is more than 50. The association of LPA concentrations and MI is highest in South Asians as well, with an odds ratio of about 2.1, which is certainly higher compared to other ethnicities. Depending on the definition, location, and population, the prevalence of hypertension ranges anywhere from 21% to about 50%. And there's certainly regional variation depending on the country of origin. People from South Asian communities are known to be up to 4 to 6 times more likely to have type 2 diabetes than the general population. In addition, South Asians tend to have poor diabetes management, putting them at a higher risk of serious health complications. Perhaps more telling is the prevalence of pre-diabetes, as described in the Masala study, the only prospective study of South Asians currently ongoing in the United States, where the prevalence of pre-diabetes was about 60%. And this certainly represents a red flag with respect to the risk of transitioning on to the development of diabetes in the future. At lower BMI values, liver fat, intramuscular fat content is higher compared with other racial groups. In addition, much of the weight tends to be central in nature. So we're talking about central adiposity. And so in this scenario, BMI calculations for South Asians may be unreliable, with more recent data suggesting that even a BMI of 23 may be too generous as an ideal goal, and that perhaps a target closer to 20, especially in the presence of 2 or more risk factors, may be better. Diet is a tricky one, but a longer length of residence in the United States is directly associated with a higher intake of saturated and trans fats, dietary cholesterol, and alcohol, for example. Alternatively, a diet higher in fruits and vegetables, nuts, legumes, for example, is associated with a lower prevalence of hypertension and metabolic syndrome. So we're talking about plant-based diets or Mediterranean type diets that incorporate South Asian foods. Genetic risk is always cited as a common risk factor. At our kitchen table, we always ask, is it the family history or is it the phenomenal halva? But I think it's important to know that the risk imparted by family history is probably similar to other populations at 1.5 to 2 times the risk. Tobacco use may be underestimated considering available cultural products that can be smokeless. So indeed, when asking about product-specific questions, this revealed very high rates of alternative tobacco use in a New York City study of Gujarati and Bangladeshi adults. The prevalence of regular moderate physical activity is generally lowest in South Asian adults. Barriers to physical activity are variable and may be particular to a religion, gender, or generation. So for example, low awareness of the benefits of physical activity, cultural gender norms such as modesty, healthy body weight perceptions, language barriers, structural barriers such as gender segregation, perceived harm thresholds of exercise, career commitments, which we all know about, racial discrimination, low levels of acculturation have all been cited as reasons for low levels of physical activity in this group. And lastly, gestational diabetes is especially important risk factor for ASCVD in our South Asian women, with very recent data between 2011 and 2019 showing the highest rates of gestational diabetes was found in Asian Indian women. Unfortunately, more work needs to be done in this arena given an overall lack of disaggregation of data amongst Asian subgroups. So to put that together, this is data from the IntraHeart study showing that the population attributable risk for coronary disease for 9 traditional risk factors that we just spoke about, such as hypertension, diabetes, obesity, low exercise, is about 86%, suggesting that the identification and management of traditional risk factors would certainly help mitigate cardiovascular risk in this population. This is amplified by more recent data from the UK Biobank, as Dr. Kathirasan spoke about, certainly a more contemporary cohort, confirming that factors such as hypertension, diabetes, central adiposity are some of the leading associations of the observed risk of cardiovascular, observed disparity of cardiovascular risk rather. So I think the next natural step after assessing these risk factors is to calculate the cardiovascular risk using available methods. So here in the United States, we use the Poole-Courts equation, and in Europe, they commonly use the Q-RISK-3. And so why assess risk? Well, the estimation of risk facilitates matching the intensity of of therapy to one's absolute risk. So in that way, we can maximize the benefits of therapy, and we can also minimize the harms of overtreatment. So said another way, this allows the identification of patients who are at sufficient risk to merit treatment with a higher likelihood of net individual and likely societal benefit as well. So for the Poole-Courts equations, this has been fairly validated, widely validated, and broadly useful in the United States clinical population. And overall, the PCE does pretty well, but it may overestimate risk in patients with or who come from higher socioeconomic status, for example, or those who have been closely engaged with preventive healthcare services. Alternatively, it may underestimate risk for those from lower socioeconomic status or those with chronic inflammatory diseases, or even certain racial groups or ethnic groups such as South Asians. And this is where the disparity with respect to the care of South Asian really starts to emerge. So while risk assessment is fundamental to guiding ASCVD risk reduction counseling, risk prediction in South Asians remains challenging for a few reasons. The first is that available risk algorithms have not been derived from or have not been prospectively validated in South Asians. So we've seen part of this curve before in the earlier talk. But for example, this is data from the UK Biobank showing that while incident CVD was higher in South Asians, as we can see here in the red line, this risk was not reflected in the Poole-Courts equations or Q-RISK-3, which actually uses a correction factor for South Asians, such that the predicted 10-year risk of cardiovascular disease, according to these equations, was nearly identical for South Asians and for those of South Asian and European ancestry. Second, limited considerations have been given to native versus migrant populations. Third, limited considerations have been given to duration of immigrant residency in the United States. And fourth, there is limited availability of disaggregated data, which likely masks meaningful health differences in this subgroup. So as you can see here, it was not until about 2010 when some effort was made to help clarify race with write-in options for other Asians. And this is further exemplified if we look at South Asian subpopulations. We see here that the risk of cardiovascular disease approaches nearly 4 times that in Bangladeshi and 3 times that in Pakistani adults, further highlighting the importance of disaggregating South Asian data. And so available population-specific risk assessment tools unreliably estimate risk in this group. And certainly this is not for a lack of trying, but rather for a lack of inclusion, particularly if we're basing our risk estimation on a cohort of less than 10% South Asians that considered other cohorts in which South Asian population is higher are currently not incorporated into any guidelines aside from the predict estimates here in New Zealand. And so how do we improve on this? Well, for many years now, groups have been advocating for the detection of subclinical atherosclerosis using coronary artery calcium. I think this diagram shows the progression of plaque formation nicely. I wanted to highlight that using imaging modalities such as coronary calcium is likely here between having no atherosclerosis and before plaque rupture or plaque disruption occurs. The utility of CAC screening is tied to the fact that the number needed to treat with lipid-lowering therapy to prevent an event is very high and often leads to overtreatment or undertreatment, as we discussed earlier. And so this is where the use of coronary calcium screening can be helpful to make the number needed to treat a little more acceptable. So just a quick primer on coronary calcium and CTA coronary with the fundamental differences shown here. Coronary calcium is indicated for asymptomatic, borderline to intermediate risk patients to help guide preventive therapy, namely statin therapy and maybe aspirin as well. It is a non-contrast-based study that measures the calcium content, including the density and the plaque area, and is frequently quantified as a score of 0, 1 to 99, and greater than 100. A score of greater than 100 typically is equivalent in risk to those found in secondary prevention populations. CTA, on the other hand, is a diagnostic test used in intermediate risk symptomatic patients. It is contrast-based, and it's basically used as an anatomic assessment of the coronary artery. It can also be used to identify burden of coronary atherosclerosis, including calcified plaque. So here are some examples that you can see here in the top left column. This is a cut through the LAD, the left anterior descending artery. And you can see in the top left picture where we've circled in red, there's no coronary calcium there as identified by the absence of any white flecks of calcium. The bottom left picture shows calcium deposition in the LAD very nicely. And that's all the information that you get out of this study. So the presence or absence of coronary calcium or atherosclerotic plaque buildup. To the right is an example of a CTA coronary scan. So in the middle panel, we see the right coronary splayed out very nicely here. This is a nice smooth vessel showing no plaque buildup whatsoever. The CTA on the far right image, however, shows luminal narrowing and evidence of calcific plaque deposition. I've shown a blown up view here. As you can see, the vessel gets narrow, and in the area where it looks like there's soft plaque. Oops. Sorry about that, don't know what happened. 1 second.
So we know that you like Chelsea then, football team.
To mix it up here.
All right, we're back.
Okay, so showing here that you have an area of luminal narrowing, and then calcific plaque deposition is shown in the bright white there. So CAC testing found increasing support in the latest lipid guidelines in 2013. It was suggested that if you had a coronary calcium score of more than 300, you will lean towards prescribing a statin. In 2018, they encouraged looking across the spectrum of coronary calcium to show that if you had a score of 0, 1 to 99 or more than 100, that would kind of stratify as to how you used statin therapy. So I think the next natural question is, how does CAC fare against some of these other risk markers? These are two studies here showing that that took only patients at intermediate risk and using risk prediction models said what would happen if we add these risk markers to a baseline risk score. So using the Poole-Courts equation as the baseline, they found that the addition of coronary calcium predicts risk better compared to other imaging modalities or risk enhancers. Said another way, when you look at negative risk markers, so no hsCRP, no carotid plaque, no family history, no metabolic syndrome, for example, what we found is that a coronary calcium score of 0 showed the best performance, resulting in the greatest downward shift in risk. So more reassuring data for the use of coronary calcium. You may have heard of the power of 0, and this comes from the idea that those with a coronary score of 0 carry a substantially lower risk of a coronary event over the course of 10 years. More recent data has extended this out to 15 years, essentially placing individuals in a lower risk category over the course of that time. So putting this back into perspective, the current lipid guidelines suggest calculating your ASCVD risk using the Poole-Courts equation. So you would use white race for South Asians, as the guidelines suggest. However, if your risk was 7.5 to 20%, the guidelines suggest the initiation of statin therapy. However, the focus of this current guideline has shifted now to emphasize the clinician-patient risk discussion. So where the decision about statin use remains uncertain, such as reluctant patients, patients who seek precision risk, patients concerned for or who have suffered statin-related muscle symptoms, older patients with fewer traditional risk factors. In scenarios such as these, the guidelines offer that it's reasonable to use the coronary calcium score if the decision is to withhold, postpone, or initiate statin therapy. In addition, the guidelines have also introduced these risk-enhancing factors to help support the decision to initiate or intensify statin therapy, of which South Asian ethnicity is one. But that's rather unfair, right? Just because you're South Asian should not necessarily commit you to statin therapy or any preventive therapy for that matter. So to help circumvent this in the absence of outcome data to derive a risk score specifically for South Asians, our group and others have used coronary artery calcium to help reclassify risk, such that if your score is 0, you could likely safely defer therapy and consider postponing therapy, if anything. And if your score is more than 0, you would be suggested statin therapy and aggressive risk factor modification. And so, as you can see here, South Asians who are low or intermediate risk groups by the Poole-Courts equation, the same calculator that we use to calculate risk, South Asians were more likely to have a coronary score of 0, suggesting that the extent of risk overestimation using the PCE may be even greater among South Asians, as we saw earlier, especially when compared to whites, the same group South Asians are defaulted to in the risk estimator. To extend these results, if we take into consideration that South Asian ethnicity is a risk-enhancing factor based on the most recent prevention guideline, we find that systemic considerations for borderline risk South Asians as statin candidates might result in considerable overtreatment, with nearly 55% of them having a coronary calcium score of 0. For those at intermediate risk, there's a 1 in 3 chance that an individual may very well be low risk. This was a nice study showing that South Asian men had similarly elevated prevalence of coronary calcium compared to white men. South Asian women, on the other hand, had a lower CAC prevalence than white women, but similar to other racial and ethnic groups in the MESA study. There are other advanced measures of coronary artery calcium that can be used to help predict risk. So an increasing body of evidence suggests that a higher calcium density is associated with decreased CVD risk, whereas CAC volume or higher CAC volume has been associated with increased risk, as I've tried to show in the plots here on the left. So some observations here from this study showing that the Poole-Courts equations and cardiometabolic risk factors are associated with both CAC volume and density. Looking at some of the individual metabolic risk factors, we see that presumably a higher HDL level may result in more dense coronary plaque, therefore more stable and less likely to rupture. In our study, we also found that a higher waist circumference was associated with lower CAC density in both men and women, while higher BMI and waist circumference was also associated with higher CAC volume in women only. So again, maybe adding more value to the importance of improving waist circumference and BMI values. This was a nice paper by a close colleague, Dr. Al Rafai, showing that South Asians have a higher number of vessels with plaque, so more often have 4-vessel coronary disease compared to whites. In addition, South Asians have higher CAC density and lower CAC volume, which would seem protective based on some of the data I showed earlier. Some other observations in this study, looking at changes in plaque density and volume. CAC volume and density is highest in the left anterior descending artery. The highest volume change was seen in the right coronary artery, and the highest change in density was seen in the left main coronary artery. Data not shown here suggests that smoking is associated with CAC volume progression. I think one would expect that, a negative risk factor leading to more CAC buildup. And exercise was associated with CAC density progression, so probably also not unexpected. Doing something positive creates more dense CAC and likely is more protective over the long term. Some more general observations here showing that if narrowing was to occur, it was more likely in the proximal LAD. And although there were less calcifications, lesions were typically longer in South Asians. Note that this study included only men, so difficult to generalize these results to the entire population. In this study, patients had a 0 calcium score at baseline examination, and then a coronary calcium score was repeated after 2 to 3 years to determine if any CAC developed. Overall, South Asian men had a higher incidence and progression of coronary calcium than South Asian women. After accounting for other cardiovascular risk factors, South Asian men had a greater change in coronary calcium compared to other men from other ethnic groups, but there was a similar change in coronary calcium when compared to white men, as you can see on the left curve over here. For women, there was no difference in coronary calcium incidence or progression between South Asian women and women of other racial or ethnic groups. CAC may also be better at informing hypertension management in South Asians. So The 2017 guidelines actually do a better job of identifying South Asians who would not only benefit from lifestyle modification, but those who may benefit or be recommended antihypertensive therapy. In addition, when comparing the 2017 guidelines to JNC7, the proportion of participants receiving discordant recommendations increased across coronary artery calcium categories. When looking at markers of inflammation, such as hsCRP, TNF-alpha, leptin, adiponectin, for example, we found that these markers were not associated with coronary calcium presence or severity in the Masala population. This led us to suggest that inflammatory markers in coronary artery calcium likely reflect distinct pathophysiologic processes and hence provide distinct information towards CVD risk prediction, similar to other cohort studies. We also found that the presence of a family history was significantly associated with a higher burden of coronary calcium score of over 300. Recall that the risk imparted by a coronary calcium score of over 100 is equivalent to stable secondary prevention populations. These results were furthered by a European study showing that South Asians with family history had modestly increased coronary calcium burden compared to European population. We've been talking a lot about coronary calcium, but here's some CTA data, of which unfortunately there is not much. But here we see among diabetic South Asian patients compared to white adults, some findings that we've just described with coronary calcium. So compared to white adults, South Asians have higher CAC scores, a higher prevalence of significant CAD, more coronary vessels with involvement, with segments that are involved as well. And if stenosis is to occur, or significant stenosis, so more than 50%, more frequently this was found in the LAD. Alternatively, this was a study of symptomatic patients presenting with chest pain compared to a white population, but this time some different results than what I showed you. So overall, there was no difference in the severity of coronary atherosclerosis, luminal diameter or luminal area. Now that's particularly interesting because narrow arteries have been cited as a reason for accelerated atherosclerosis in South Asians based on earlier studies in Europe in the mid-1980s comparing South Asians to white adults. In addition, in the study, they found that the percent non-calcified plaque composition was higher in South Asians compared to whites, so more dangerous plaque at risk of rupture. And Caucasians had slightly higher calcified plaque burden than South Asians, although this difference was significantly lower or smaller. Now, notably in this study, South Asians were younger at the time of presentation, about 6 years younger, and had much higher rates of diabetes as we have described before. So at least for South Asian men, and of course I wish we had something better for women or South Asian in general, but perhaps one place we can use some of this coronary calcium data is in the MESA risk calculator, given similar prevalence of calcium and progression of calcium to further risk stratify using white men as a default for South Asian men. So quickly, switching gears here, I think if we see a South Asian patient in our clinic, they should be applauded for coming to seek in preventive care. Available evidence suggests that South Asians may be reluctant to seek routine care due to unique barriers, such as existing cultural attitudes, such as fatalism, which lay foundation in the belief that all events are predetermined and therefore inevitable. Lack of transportation is especially problematic for elders who cannot drive and or speak English, or those who live in multi-generational homes where the grandparents are typically at home and the children work. Children can help facilitate interpretation. However, this method is prone to incorrect or incomplete communication when children lack the appropriate medical terminology, lending itself to delay of care in the elderly. Also, lower rates of English proficiency is a predictor for higher traditional Eastern medicine health practices. And certainly racism and discrimination are related to self-reported poor health in South Asians. Lack of health insurance and high out-of-pocket expenses for appointments and prescriptions may also be problematic, considering the emergence of income inequality in this population, according to recent Pew data. So how do we bridge this gap? Well, we should be able to provide culturally available resources. This is from the American College of Cardiology website, showing that decision aids that were used, or that are offered in few other languages, none of which are the major languages native to South Asian countries, such as Hindi or Urdu, for example. Certainly, this is not a unique phenomenon, despite a call to action in 2018 by the AHA. Resources for primary prevention remain in English. Even on their international website, Hindi, the third most spoken language in the world, was not offered as a language. A good example of this deals with describing healthy eating. It can be challenging to do so if foods do not exist in the English lexicon. To help make this culturally relevant, this is a nice infographic from the National Lipid Association that I actually use with my patients, and it was designed specifically with South Asians in mind, suggesting to choose whole grains, lower fat intake, increased plant-based protein, and additionally important exercise portion control. What stands out to me is naming foods that are part of a traditional South Asian meal. I like this because it still fosters the enjoyment of traditional foods, just with a recipe makeover. Religious considerations should also be taken into account. So for example, managing chronic conditions during Ramadan fasting, as we all know, can be challenging, especially as patients may prioritize fasting over health concerns. Interventions aimed at increasing neighborhood social cohesion using community-based participation tailored to beliefs and modesty, as well as gender-specific measures and programs, may also be an effective measure to influence physical activity, particularly for initial immigrants and subsequent generations. This is actually an example from my hometown in Toronto, Canada, called the Muslim Women's Summer Basketball League, whose mission is to create an environment that values Muslim female athletes, fosters sisterhood, mentorship, and is an inclusive or creates an inclusive community through basketball. So to summarize, I think we start with the fundamentals of identifying and managing traditional risk factors specific to South Asians, focusing on things like blood pressure, diabetes, dyslipidemia, and obesity, for example. I certainly would encourage and suggest the use of coronary calcium to further risk refine to determine if there is a benefit for adding on preventive therapy such as aspirin and statin, for example, specifically for those where the coronary calcium score is more than 0. And lastly is to be aware and cognizant of the barriers that we've listed here and discussed earlier. That being said, we've certainly seen that optimizing health works in other population. This is data that was presented at ACC by our team that we hope to publish soon, showing that the incidence of coronary calcium was lower over time among those South Asians who were able to improve their health according to Life Simple 7 metrics. I guess we should update that now. They have the Essential 8, which includes sleep, which none of us get enough of. And I was certainly fortunate to have an opportunity to discuss this topic in other arenas. This opinion piece we wrote essentially highlighting that while there may be other influences or novel risk factors unique to South Asians, much of the population risk is in fact due to traditional risk factors. As such, early awareness and management may very well curb the high rates of cardiovascular mortality in this group. Certainly the use of coronary calcium can help stratify risk as we've seen today. Before I end, I wanted to ensure you knew how to find us. We have 2 locations and are actively looking to guide our South Asian patients along a healthy path forward. We are the premier comprehensive South Asian cardiovascular clinic in the region, and we look forward to taking care of your patients and their families. Ladies and gentlemen, I thank you again for the opportunity. My name is Jaydeep, and I will, I guess, turn it over so we can start the panel discussion. Thank you.
Thank you. Thank you, Jaydeep. Excellent discussion about imaging and the social, cultural, ethnic, all the background, holistic. That was very nice. Now, Ravi, Dr. Om Gonda is on the line. He's another eminent endocrinologist from Harvard.
Yeah, Dr. Ganda.
You would like to ask a question. Can you unmute you?
Yeah, let me try it. 1 second. And we have a couple of hands raised, and there are a ton of questions. I collected them all. Let me get Dr. Ganda.
I'm writing them after Dr. Ganda's comment.
Okay, let me get him. Thank you.
In the meantime,
go ahead.
In the meantime, Dr. Sekhar, can you comment on the role of LPA? That was the first question that was posted.
Yeah, in our work to date, there are 3 main axes of risk when you think about lipids and lipoproteins and risk for coronary disease. The first axis is LDL. So that's kind of represented by the PCSK9 gene, for example. The second axis is related to triglyceride-rich lipoproteins. So that's represented by genes like A and GPTL3. And the third axis of risk is lipoprotein little a. And what has emerged from the human genetics research is if you had all three of those low, lifelong, again, it's really hard to develop atherosclerosis. So LPA is an important factor that drives athero. There are treatments that are emerging, as you know. There's an antisense oligonucleotide that's been developed, that is being developed by Novartis, that is in a phase 3 clinical trial right now, that specifically lowers blood Lp(a) by about 90%. We'll find out, I think in 2025, in the 8,000 person randomized controlled trial, whether that lowering also translates to reduced risk of heart attack. And that'll be the first outcomes evidence for LPA lowering. So it's an important risk factor. We'll find out soon if lowering it lowers risk of events.
Thank you so much. I'll come back to you. More questions for you, Dr.
Brahma, can you hear me?
Yeah.
Sundar here.
So, hi, Sundar. How are you?
Good, good.
So we have a distinguished endocrinologist from my alma mater, Jaipur, Dr. Om Ganda. He's a diabetologist from Joslin, Harvard. He's the connecting link between Indians and the heart disease. Om, go ahead and make your comment and question.
Thank you, Brahma, and thanks to AAPI for organizing this wonderful symposium today. And of course, Shekhar and I both are in Boston. Shekhar, so nice to see you. I just have a general comment. I have a couple of questions, but I'll keep it brief. I think you were among the first ones to show that the genetic polymorphisms of HDL don't really make a difference on cardiovascular risk. And I quote you all the time about that fascinating study comparing LDL, HDL, and VLDL triglyceride. So the question is, we all know our patients and friends who have been taking up to 8 grams of niacin to raise their HDL to the sky. And so this is a well-known scenario, which is changing now very rapidly after the 2 major studies in HDL raising. So the question was, do you have any insight into whether we have any further inroads to make in the HDL functionality, knowing all the epidemiological evidence? And the second unrelated comment was really just to mention that your ANGPTL3 looks even more exciting considering the IDL and the triglyceride issue.
Thank you. Yeah. On the HDL, thank you for that nice words. On the HDL issue, just to catch everybody up, I think that we all know that low HDL is correlated with increased risk of coronary disease. So that's well established. And the question over the years has been, is that correlation just mere correlation, or is it causation? Is low HDL actually causal for disease? And why does that matter? Well, it actually doesn't matter for risk prediction. If you have low HDL, you are at increased risk for disease. Why it matters, whether it's cause or just mere correlation, is for treatment. Because if it's just mere correlation, then increasing the HDL would not necessarily translate into reduced risk of heart disease. But if it's a causal factor, then a medicine that directly increases HDL would reduce risk. So that's been the key question over the last, let's say, 10, 20 years. We've known for 40 years that there's a correlation. And the question has been, is it cause and effect? And the definitive way to check for cause and effect is, as you know, is to develop a medicine that specifically raises HDL and then check in patients in a placebo-controlled randomized trial whether that medicine also reduces risk of events. But ahead of that, we and others wondered whether human genetics could help disentangle cause from mere correlation. And what we did was looked at gene mutations that raised HDL cholesterol in this case, and asked whether the people that carried the gene mutations that raised HDL lifelong for them, whether those individuals were actually at lower risk for heart attack. That's what you'd predict if it was a cause and effect. And what we found surprisingly was that individuals who carried DNA mutations that raised their HDL lifelong had the same risk for myocardial infarction as those who didn't carry those mutations. suggesting that HDL is a marker of risk rather than a causal factor. This was published in 2012. A few months later, actually, the first of these large-scale trials testing HDL raising agent called dalcetrapib, which specifically raised HDL by about 40% and did nothing else, didn't change triglycerides, didn't change any other risk factor much, if at all. And it was tested in about, I think, 13,000 patients. And the medicine raised HDL, but had no effect on coronary events. So this has been supplemented now by a couple of other trials. So really now, I think it's pretty clear that the blood HDL level is a marker of risk, but not a causal factor. So then the question becomes, if it's a marker, what is it marking? Why are people who have low HDL, why are they at increased risk? It's not because of the HDL. It's because of something else. It's marking something else. And the best evidence that we've been able to gather and others have been able to gather is actually marking the high triglycerides. That the triglyceride-rich lipoproteins that the low HDL travels with is actually the causal factor. And so that's, I think, where I've kind of, I think the evidence points to. And so I like to summarize it very simply. I showed that slide earlier of lipoproteins, and you can break them up into HDL, which is an ApoA containing lipoprotein, ApoA1 containing lipoprotein. And then you have the rest of them, LDL, LP(a), triglyceride-rich lipoproteins, which I collectively called ApoB containing lipoproteins. And what matters for atherosclerosis are those ApoB containing lipoproteins. So B for bad. And only those three things matter. It's the LDL, it's the triglyceride-rich lipoproteins, and the LP(a).
Excellent, excellent, Shekhar. So on the same theme, there are two other questions if you can comment on. One is what is the role of particle size? Does it have any clinical relevance? And should we order ApoB more than LDL as a better marker? And is it worth the cost?
Maybe I'll defer those questions to Dr. Patel.
Great questions. So ApoB is interesting, as Zach mentioned. That is the atherogenic risk particle. I think LDL gives part of the story, but especially in high-risk ethnicities where you think that there may be some familial or genetic component to what's going on, I will frequently check the ApoB to see if there's underlying atherogenic risk and use that to help risk stratify patients. I think the LDL gives part of the story, but it's the ApoB, as we mentioned, that may be the more troublesome. And in that situation, I think that the risk benefit would favor checking that value.
Excellent. So next
Brahma, quickly, hi. I just want to congratulate Ravi and your TAPI board for putting this fantastic program together, AAPI board rather. And Sheikh, that's a brilliant presentation. Also, Jaideep, quick question for Jaideep about this coronary calcium thing. So in clinical practice, we are, I've been ordering this for many years now. But if somebody is already taking a statin, is it worth doing a coronary calcium score? I mean, there's some data that, statins may actually increase the coronary calcium score because it probably makes the plaques more dense and less prone to rupture. So what do you think?
Yeah, no, that's a great point. So I think this goes back to kind of what we had said, that coronary calcium should be a one-time check, and we use it typically in patients who are borderline or intermediate risk when you're trying to make a decision, should you or should you not go on a statin. So if you do a coronary calcium score at that time and it is a low, 0, ideally, you would say you could probably safely defer. I think the challenging portion of South Asians is we don't know how often to repeat the scan if you are going to repeat and you have a 0 calcium. So for example, you draw from other higher risk populations such as Hispanic or diabetics. Some people will argue that maybe a repeat check in about 3 to 5 years is the right time to do that. And so we don't have any data to suggest that that might be different in South Asians. But but given at least some of the data I showed earlier, 3 years probably would not be unreasonable. So in that scenario, you would say, okay, now let's get the scan, and you see calcium, then you would say, yeah, let's start treating. But if someone came to you and was already on statin therapy, the benefit of having a coronary calcium score is fairly limited, because as you mentioned, there is data to suggest that statins have a pro-calcific effect. So in addition to pulling down the lipid, there is anti-inflammatory property, and they also help to solidify any soft plaque. That's certainly the dangerous plaque. And so you wouldn't, so if the other common scenario that we have is someone has been started on a statin, they get a calcium score, and then their calcium score is, I don't know, 500 over a 3-year time or something like that. Patients also want to know, should we intensify statin therapy? And I think that is a challenging question too, because no one really knows. But I think that to answer your question, if you're already on a statin, it does have pro-calcific effects. And so you really don't need to get a coronary calcium score in that situation. The other time where I see calcium scores, side note, is someone who's already had an event. They've already had a heart attack. They've already had a stroke, already on statin therapy, and someone gets a calcium score to risk stratify. And that's not the right arena for this also. In the setting of secondary prevention, they are already kind of destined to be on aspirin and statin.
Thank you. Ravi, can you invite Sundar? Can you invite Sundar as a panel? Ravi, can you bring him?
He's on the panel.
I'm on.
Yeah, Sundar is another eminent cardiologist in our community.
No, I'm not eminent.
Friend, he's in Spain right now. So coming back to Jaideep, there's a question. What is the threshold, 100 or 300, for calling something like a secondary prevention? Where do we reach that threshold?
In a lot of the data that has come out from coronary calcium, 100 is the threshold of what you would consider a stable secondary prevention population. So
I'm a psychiatrist, so I'm completely out of depth here, but let me ask you a question as a patient perspective.
Sure.
And the statins, I think one of the point is the family history makes a big difference in how you assess the risk as well, right? Not just the patient himself. And the second thing is number need to harm as far as the statins are concerned in a preventive care versus secondary prevention. What's your thoughts on that? As opposed to number needs to treat versus number need to harm, for example, diabetes and things like that.
I mean, I think the number needed to harm is very low. I think there was a lot of data that came out a lot earlier. Patients, and these were majority observational studies showing that statins cause things like muscle symptoms, myalgias. I think the prevalence was in some studies as high as 30%. But again, these were kind of observational studies, majority of them anyways. Do statin-associated muscle symptoms occur? Yes, I have patients that get put on an intermediate dose statin. They have side effects. The risk of diabetes is also very, very low. I think in the realm of less than 5%. And I think the general argument in the community is that if someone is to develop diabetes, they were probably destined to have diabetes anyways, meaning they were already on that trajectory, and maybe this kind of tipped them over, but in all likelihood, they probably would have developed it. So I think that the benefits of statin generally outweigh, and this goes back to sex conversation where it's the lifetime exposure of LDL that kind of gets you into trouble. And so anything that we can do to mitigate that risk would be beneficial for that patient.
So another question, Sekhar, for you in that realm where you are dealing with, where does the inclisiran fit into all these kind of things, lipid-lowering therapies?
Yeah, I think that in the current era, there's a range of options for LDL lowering. There's oral medicines, right? So basically statin and ezetimibe. So these are daily pills. There's a set of injections. There are 3 injections that are possible. One is Repatha, second is Praluent. Both of those are monoclonal antibodies that target PCSK9. And then the newest addition to the armamentarium is inclisiran, also an injection, but injection that's given less frequently. So both Repatha and Praluent are given typically every 2 weeks or once a month. Inclisiran's main advantage is that it can be given as infrequently as every 6 months. So it's an injection every 6 months. The LDL lowering effect of inclisiran is not as good as the monoclonal antibodies. The LDL lowering effect of inclisiran is about 40 to 50% LDL lowering. The monoclonal antibodies can get from 50 to 60%. But again, inclisiran can be given less frequently. In studies, it seems to be well tolerated. Now, the monoclonal antibodies do have the outcomes trials completed. So we know for that class of medicines, there's LDL lowering benefit as well as cardiovascular outcomes benefit. Inclisiran, the cardiovascular outcomes trial, is ongoing. But it's a very good option for patients. I think there are, it's just being rolled out. It just got approved. And what I was trying to show with Verve 101 on our medicine is that there's all these medicines that follow the chronic care model, daily pills, intermittent injections, and can we get rid of all that and just have a truly a one and done? And that I think time will tell. But there are a lot of challenges, as you all know, with the chronic care model. The number one, I think, very discouraging statistic is that if you look about a year out from somebody's myocardial infarction, less than half the patients are taking any lipid lowering medication at 1 year after an event. That was an analysis that was done recently of 600,000 patients in a large healthcare plan. And why is that? Despite all that's available, a lot of that has to do with the chronic care model and all the requirements it places on physicians and patients.
So one more.
That's interesting. That's interesting, Sheikh. As a psychiatrist, we have a lot of adherence problems. I thought the problem is unique to our field. Even for cardiology, people dying of the disease don't want to take the treatments and follow up.
Just 1 year out. Just 1 year out from an MI.
Scary. Yeah.
One more point in that connection is that, do you start like after the event? This is for Shekhar, or are you planning to start as a primary prevention, this gene editing therapy?
No, for any new therapy, as you know, you'd want to start with the highest risk patients to evaluate the risk benefit profile. So this is a brand new type of medicine, right? So we'd want to start with people who are the absolute highest risk. And that's why we're starting with the FH patients, the patients who have a genetic form of high LDL and have already suffered an event. We want to show the efficacy and safety of this new medicine in those patients. And then we can progressively, move to earlier and earlier. So I think the development path is FH first, then garden variety ASCVD patients, maybe shortly after their MI, and then primary prevention. This is really how the clinical development for new LDL lowering medicines has gone.
Is there any evidence that the plaques would be reversed if you have multivessel disease in these patients, since you're starting this therapy after they have their MI?
Yeah, so we have to look to the evidence of regression from the monoclonal antibodies or from statins, for example, because those have all been started, right, in patients who have already had an event. And there are actually a bunch of trials over the years of whether if you get the LDL really low after an event, can you get regression of the plaque, or are you just stabilizing? And what those studies have shown, and these have typically been like intravascular ultrasound studies that have looked at the walls of the vessels at the time of the initial angiography and then over time with follow-up and then having LDL get really low. And I think there's some good evidence, particularly with high dose Crestor and with the monoclonal antibodies, that you're not just getting plaque stabilization, but with ultra low LDL after an event that you get regression.
This is a quick question to both of you, Sheikh, and also to Jaideep. We're all in that same age group, Brahma and Ravi and all that. So we have kids who are born and, growing up over here. Do they really have the same risk as our first generation Southeast Asians?
In that context, I think some of the early nutritional deficiencies, intrauterine, even early childhood, do you think that has anything to do with the pathogenesis of atherosclerotic heart disease, which is becoming a popular topic of discussion and research? I
could probably try to take the first question here. I think the shorter answer is we don't know because there is no data. We don't have any good information on first generation South Asians. or sorry, second generation South Asians rather. The Masala study out of UCSF and Northwestern, like I said, is the only prospective study kind of ongoing with some of that information. They recently enrolled second generation children of some of the original participants, very small cohort, maybe less than 50. And already you're starting to see some of the overlap of things like diabetes, high blood pressure, and dyslipidemia. So, I think some of this is also built into shared risk and also shared environment. And that maybe influence a little more kind of looking forward. That being said, certainly as someone is second generation and grew up here, my version of it is a little bit different compared to, say, my parents coming to this country. And certainly getting an opportunity to do more or be exposed to more of an American style diet and lifestyle as opposed to what my parents did. So I think that, the shorter answer is, like I said, we just don't know, and hopefully that data continues to emerge.
Sundar, is a great question, actually. So one of Dr. Patel, who did that study that both Anurit Patel, who did the study that Jaideep and I showed in UK Biobank, this large cohort study in the UK. He's actually done another analysis. I can actually share the screen. He just sent me this data last week. This is looking at, this is unpublished, looking at South Asians born in the UK, South Asians that have been there for greater than 5 years, and South Asians less than 5 years. So the first 3 rows. And you're looking at the hazard ratio for events. And you can see that basically they're all quite similar for a range of different events, diabetes and stroke and so forth. So at least in this data set, it looks like the South Asians are at high risk, regardless of whether you're born in UK or you are an immigrant.
On a lighter note, I just want all of you to know that changing your citizenship doesn't modify your risk.
You can edit the gene by the technology, but I don't think you can edit your ethnicity, I guess.
So, Shekhar, can you also comment on epigenetics? Can lifestyle change and all these things we do, can we mitigate some of the genetic risks that we inherit?
Absolutely. And I think this is data that I didn't get a chance to share, but that polygenic risk, and I think there was a question that was somebody sent in as well, that polygenic risk that I mentioned, for example, you might think, okay, well, I have inherited risk. Am I destined or doomed to have the problem? But it's pretty clear that in this case, the DNA is not destiny, that you can actually modify the inherited risk. And we showed that if you're ideal on just a few lifestyle factors, you can offset the inherited risk by almost 50% or more. And then the other intervention that can offset the inherited risk is actually getting somebody's LDL lower. And so it's really, there's definitely stuff you can do to offset the inherited risk.
Thank you. Jaideep,
Dr. Ved Gosain, I think, asked about, is any polygenic model, multiple genes be edited in the polygenic model?
That's a great question. I think that polygenic model that I showed is literally like millions of spots in the genome. So it would be hard to envision editing all those. I think probably the main intervention that I can see in the future for somebody who's high polygenic risk on a test is actually what Dr. Patel talked about, all the things we do now in terms of lifestyle, also LDL lowering. And so that's probably the major way to go. In terms of our own work at Verve, we're developing multiple products, in terms of gene editing. And so, for example, a product against LDL, a product for the ANGPTL3 that target triglycerides, and then ultimately maybe even a product for Lp(a). And I could imagine a future where somebody gets a couple of edits, 2 different medicines from us to lower both their, for example, LDL and their Lp(a).
Excellent.
Jaideep, one question for you. At what level of calcium score, 300, 400, 800, do you recommend a coronary CT angio, even if they're asymptomatic, or cardiac cath?
Yeah, I don't necessarily do that. I think that the problem with doing a study like that, if they're asymptomatic, is the utility is low. Because even if you have evidence of obstructive coronary disease and you're asymptomatic, there is no indication to put a stent into anything like that. I think the bigger risk for me, at least what I've seen, and this is just kind of off the top of my head, I've had or been involved in cases where patient was referred for example, heart catheterization. So this is obviously a more invasive procedure, but similar to a CTA in terms of assessing the coronaries. And even though they have high plaque burden, this can lead to risks such as plaque shift and kind of disrupt or dislodge plaque that may otherwise have been stable. So even in the presence of elevated calcium score, I don't typically suggest a CTA. This also goes for other modalities. So I know there have been some recent stuff that had come out at a recent national meeting saying that if you had a coronary calcium score, maybe you should undergo stress testing. Same idea, unless the patients are symptomatic. In my practice, at least, I don't typically assess them unless they're actively having complaints of chest discomfort, shortness of breath, because that is a different person profile compared to someone who's asymptomatic and just coming in for a coronary calcium score.
Jaideep, what about the location of the calcium? A few times that I've ordered a coronary CTA is when somebody's come to me with a very high score, most of it concentrated in the proximal LAD left main sort of thing.
Yeah.
And there it's very hard to tell, So that's the only time I order a coronary CTA.
Yeah.
There's another question by Dr. Batina. He says, I was part of a small observational study. Calcium was more in the intima in Indians compared to other ethnic groups where the calcium is found in other ethnic groups, mostly in the median and adventitial layers. Can you comment also while answering Sundar's question?
I'm not sure. That is a good question, and I don't know if it has any clinical relevance. I mean, calcium deposition is a result of healing. So there's lipid pools, and as a result of part of the healing process, calcium kind of develops almost like a shelf to try to protect some of that loose plaque from getting into the bloodstream, which is what causes you to have a heart attack. But I don't know of any studies that have shown any clinical relevance to that, other than maybe just observing that may be the case. If that is a study, I'd love to see it.
Okay.
So one question is coming is that how low you want a LDL in a patient with a primary and secondary prevention, how low you can go given the evidence of regression in coronary CT angiography and plaque remodeling and plaque stabilization, all that we read about.
I think the general rule is less than 70. There is this is more expert opinion that in South Asians, you should push a little lower. Like if they have additional risk factors, you put less than 55, maybe even less than 30. There's kind of, I don't think any harms to having the lowest low LDL rather. Sek may be able to comment on that a little bit better, but in general, I commonly will say, even if you have coronary calcium met for primary prevention, the LDL goal is less than 70. If you have additional risk factors like diabetes, hypertension, I will usually try to push them lower.
Yeah,
Let me ask a composite question about COVID and heart disease. Does COVID infection increase the risk of CAD? And has the COVID infection or COVID vaccination increased the heart disease and heart attacks? And finally, I think the last point here was, what about mRNA? COVID-19 vaccine has been working and proven to be safe. What is your comment on mRNA for reducing CAD? Thank you.
Maybe I'll take a couple of parts of that. I guess the previous question is about the LDL, getting back to that. Actually, there's really good evidence that the lower the better. And we're probably all meant to live at an LDL of like between 30 and 40. Because babies, when they're born, they need a lot of cholesterol. Their LDL is like 30, 35. If you look at these humans that have been identified that completely lack, for example, the PCSK9 gene, or in our case, we found people who lack the ANGPTL3 gene, their LDLs were 30, and they're fine, they're healthy. And then you look at all the clinical trials, the statin trials, the PCSK9 trials, some important fraction of those patients have really low LDL in the treated group, maybe 10, 15, 20, 30. And there's been a safety analysis of all those people with very low LDLs, ultra low LDLs on treatment. and there's no safety signal in the treatment trial. So I think, the US guidelines say less than 70. The European guidelines now are less than 55. I believe the US guidelines will change probably in the next couple of years. So if you have established disease, I think you get it low as feasible. And that's your best chance of either stabilizing or reversing the process.
Sek, if you remember, there's a analysis from the Improve It trial where they showed there was no real threshold of risk.
Yeah.
So yeah, it doesn't matter how low it is, you still are at risk, unfortunately. So,
Yeah.
so even lower is the better, I gather, in those
Yeah.
circumstances.
That's right. Getting back to the mRNA and the COVID, on whether COVID has increased coronary disease, maybe I'll leave that to Dr. Patel because I'm actually not sure of that data. On the mRNA and its role in treatments for heart disease, I think that what we're trying to do, right, is one example of using mRNA. We actually, our drug, we designed this in 2018, looks like a COVID vaccine. It's basically an mRNA packaged in a lipid nanoparticle, except we're not delivering it, intramuscularly or subcutaneously, but rather delivering it intravenously, and it goes to the liver and does a different job of editing the DNA rather than provoking an immune response, a vaccine response. But it's using a very similar technology as the COVID vaccine. So mRNA is going to be a very important part of a range of therapies going forward. On COVID and coronary disease, Jaideep, I don't know.
Yeah, I'm not sure if there's any risk of accelerated atherosclerosis in the setting of having COVID. We wrote about this for the American College of Cardiology, and I think it's akin to having the flu. So if you get the flu, you're at a higher risk of having a heart attack. And I think the idea is that there is this inflammatory response, and that causes plaque instability. And that increases your risk of myocardial infarction more than anything else. So there's already existing plaque, and that breaks away, and that's what gets you into trouble. This is why for secondary prevention, for example, we always say, make sure you get your flu shot every year. So that's all I can kind of add to that.
I just have a comment about it. I think it's excellent presentations, Dr. Sekhar and Dr. Jaideep. Wonderful. I think you learned a lot about this gene. I think a gene therapy we've been talking about, I think is the real time. We are there right now. So I think I just want one caution about the calcium score. In my cardiology practice, every year I see at least 3 to 5 patients with a calcium score of 0 with a soft plaque alone coming for with an MI or 90%, 95% stenosis with the symptoms, with the stress test being positive, even though calcium score being negative or 0. So I think there are still group of people who only have a soft plaque without having the calcifications. Jaideep, I think, do you have any comment about what percentage of the people you see are in the studies show only soft plaque? And is there any testing going on right now in a research environment where we can identify that soft plaque? And for Dr. Sekhar, a question about, I know there is a heterogeneity, thrombogenicity, plaque rupture, and sudden death. There are different parts of this equation in cardiology, not just the blockage alone. So with this genetic mapping or pooling, you can identify who are more prone for plaque rupture or sudden death, and can we do something about it? Thank you.
So I think to your point, again, I think the idea is that the challenge of prescribing medication is having people adhere to the medication. And so in primary prevention, that may be especially true, or particularly true. So doing things like a coronary calcium score is akin to showing patients something that they didn't know that they have. So for example, outwardly, you can see that, you have something growing on your arm, you want to go get it checked out. You do a coronary calcium score, you show patients that there is plaque, show them that there is disease, they're more likely to be, to start therapy and to remain on therapy is kind of the other idea. Now that being said, a coronary calcium score is not foolproof, as you mentioned. And that's kind of one of the biggest knocks against using coronary calcium is that there is still soft plaque that may be evident. And so that patients should still continue to do all the good things that they know they're supposed to be doing, like watching their diet, exercising, sleeping well, all the general primordial and primary prevention things that we kind of like to talk about. I don't know of any study. This is when CTA comes in to say, well, And there is a study coming out called the My Heart Study, or the Miami Heart Study, which is led by a close friend of mine, Dr. Karam Nasir in South Florida, where they took about 1,000 patients or more, actually, if I'm not mistaken, and had them all do CTA. So there's still a good percentage of patients that have soft plaque, but outcome-wise, these patients, the likelihood of an event is still very, very low, even at 5, 10, and 15 years. So yes, it would be unfortunate if you were one of that, 1.8% at 15 years where it happens to, but I think that a coronary calcium score should be used in the setting of, yes, this is reassurance that their likelihood of a heart attack is low, but in the setting of continuing to do all the good things that you're supposed to be doing.
Srini, I had a quick question for you. That's a great comment you made. Were those patients having symptoms? Because, that would be a wrong usage of the test. I mean, if they're having symptoms, you don't want to use a coronary calcium scan to try and stratify that risk.
So I think they had a calcium score a year ago on a routine asymptomatic. Now they come back and say, hey, I'm having chest pain, but my calcium score was 0 last year. Should I do anything about it? So that's where I think we had to do that. Like I did a stress test and found out that there was a significant blockage. Thank you.
Yeah, in terms of, you asked about the different pathways for risk beyond lipids, lipoproteins. There clearly are other pathways, blood pressure, and thrombosis. So those are probably the key beyond lipids. But what's interesting about lipoproteins is they're kind of, they really are necessary. And if you took it away, almost, this may be a little controversial to say, but almost nothing else matters. So if you really have LDL of 25, 30 your whole life, it almost doesn't matter what else is going on. You're not going to get atherosclerosis. So that's, I think, pretty clear from the human genetics and even the epidemiology. Like if you look in, rural China, for example, where the mean LDL in the United States is 130 right now, the mean. The mean LDL in rural China is 70. And that means, a lot of people are like 30 or 40, right? So they don't really have much atherosclerosis there. So I think there's a good amount of evidence that this is the absolute required factor for disease.
Steak, have you seen any loss of function mutation in HMG coenzyme A reductase?
No, because it's basically essential, right? Because it's cholesterol synthesis. But there are not complete loss of function. So there are partial that are gene variants that modulate the level of HMG-CoA reductase and change LDL in populations by a little bit. We actually identified one of the first one of these by about 2 milligram deciliter. Okay. So if you carry a one letter, versus another letter at this HMG-CoA reductase gene, which is the target for statins, you might have 1 milligram or 2 deciliter higher LDL. It turns out that when you look in large populations and ask if the people that carry the flavor that increases LDL in that gene, are they at increased risk? They are. And conversely, the people that carry the flavor that lowers LDL at that gene, are they at reduced risk? They are. So this is also this is post hoc, but another good evidence example of genetics kind of potentially pointing to targets.
Because most of them turn diabetic, don't they? I mean,
you mean the HMG-CoA reductase? No, there's not much of a risk for diabetes, as Dr. Patel mentioned earlier.
Because I think it's so closely linked, that the insulin receptor gene and the HMG coenzyme A on the genomes.
So while I'm in the midst of some eminent and really excellent cardiologists, let me ask you a question as a psychiatrist at the curbside consult. There is some correlation or some evidence that the lower cholesterol levels increase suicidal behaviors. Any comments on that so I can tell my patient not to stop the statins?
I think there's been a lot of work, and there was a question here about neurocognitive or neurologic effects of very low LDL. This is similar to the muscle side effects. There's a lot of press about it, but actually when objectively evaluated in clinical studies, in randomized clinical studies, there's really no signal for neurocognitive side effects. That was very closely tested in this study called Effinghaus by the makers of one of the PCSK9 monoclonal antibodies, because the FDA required it. And this is a randomized controlled trial. One group got the PCSK9 monoclonal antibody, the other group got control. And then they had serial neurocognitive evaluations of like really high intensity. And over time, there was really no difference between the two groups, despite the fact that the one group had much, much lower LDL. So I think that, you know, it's often talked about, but I think there's not much evidence. I don't know if Dr. Patel, if you want to.
Sek, you know, quickly, I think this controversy came up many years ago with the GEM fibrosol study. You remember that one? With the GEM, people were jumping off bridges because they thought the lower cholesterol was making them suicidal.
Yeah, I guess I can tell my patient.
That was the origin of that controversy.
Yeah, I think there's a lot of, yeah, Dr. Patel, I don't know if you.
No, I was going to say the same thing. I was actually going to cite the same study that I think that a lot of that information came out and caught wind of the media. And so there was a big hype around it, but I don't think that ever bore out to anything significant.
Good news. Thank you.
Well, thank you both very much for giving your time, valuable time this weekend. We really appreciate your input. I will continue to generate and get in touch with you from time to time. I just want to refer back to Dr. Kohli for any final comments.
Brahma, I want to congratulate you. Awesome job.
We all need to be congratulated for having such a great speakers and keep this discussion going, because every life is worth saving. Whatever we can do in the communities and our hospitals and clinics in India, awareness is the key. So Ravi, back to you now.
Yeah, I think it's one of the highest attended webinar and highest interactive webinar with excellent questions and excellent participation, excellent moderation. I think this is going to be like raising the bar of our CMEs today. I think I want to thank you, Brahma, Sundar, Srini, Dr. Saraf, and of course, our really excellent speaker, Dr. Kathrison and Dr. Patel, for sparing your time and giving us some very, very, very valuable information. I think all our members will echo the same sentiment and statement. They're all asking, where can we watch this? That is a kind of testimonial for your effectiveness of your presentation. We're going to display a virtual plaque for both of you to invite you to be a member of our speakers, excellent speakers bureau, and our office is getting ready. And please join us at our convention as well, and we would like to have you as CME speakers at our national convention in Philadelphia, not too far for both of you, in July of 2023, between July 6th and 9th. Here comes the plaque to Dr. Jaydeep Patel for his outstanding contributions in the field of cardiology, and we welcome you as a member of our AAPI Distinguished Speakers Club, signed by Dr. Srini Gangasani, our CME chair, and myself. And the next plaque is to acknowledge Dr. Kathrison, our Pittsburgh native and son of our Pittsburgh Steeler fan, hopefully still. And welcome to our distinguished AAPI Speakers Club. Thank you again. Really, we appreciate your participation. And also all the members, please join for our CME program. We are really scouting for excellent speakers to join and educate our members.
Thank you, Anita, for your time to moderating this session as well.
Thanks for
Thank you,
inviting me.
everybody. Yeah,
Enjoyed it.
thank you.
All right, have a great day. Bye-bye.
I think the presentation is so good. The Srini stopped rounding and stayed put for
I know.
Left the cath lab.
Yeah. Thank you everyone for doing an excellent job. Especially Brahma and the team, I think, putting together an excellent talk. The next CME talk is on 11/9, 1 week before Thanksgiving. After hearing all about this cardiology and how you can prevent the cardiology, next topic is lifestyle medicine. Do you want a carrot or a stent? Do you pick? That is the one thought. And then the sleep, master lever of health. So I think there are two lifestyle speakers, some excellent speakers coming up next meeting on 11/19. Please join us so that you won't get to the cardiologist in your next 15 to 20 years at least. Thank you very much. See you on the next meeting on 11/9. Thank you. Appreciate
Thank
it.
you. All right. See you.
Ravi,
Thank you
thanks
so
for putting me on the panel. I couldn't come on video because I'm still in my lungi.
No, you can do a lungi dance. Anyway, good afternoon and have a good day. Thank you all. Bye.